Mannitol, because of its osmotic effect, will prevent intracellular swelling, plus is a free radical excavenger, so hopefully will minimize the damage induced by free oxygen radicals. And heparin, because when there is no circulation, there can occur micro clots within the microcirculation. So that's what we do. Chill them and perfuse them with this pharmacologic cocktail. When we use the extracorporeal circulation, again, the circular design has a different separate circuit which will give blood to the kidneys alone, and the blood through a heat exchanger is cooled at 5 degrees centigrade. So blood perfuses the kidney and it chills them at the same time. So in essence, we chill them. And that prevents, if you look at creatinine as a greater than 40% rise compared to pre-op. So if you define the renal dysfunction as a greater than 40% increase compared with pre-op, the incidence of renal dysfunction is about 40%. In other words, a lot of people will get the creatinine from 100 to 150, from 150 to 230. But usually plateaus and then goes back to their previous state. If you look at dialysis, again, the entire series, the dialysis I had was 8%. So very similar to the paraplegia. Okay, does that answer your question? Any other questions?
So at what point is it that, what criteria are you using to say the patient now can leave the intensive care unit and come to the unit and come to the floor?
That's a good question. It's a good question because basically my idea is they stay in intensive care as long as they are good to go home. I mean, I'm exaggerating for effect. I was trying to elicit this reaction.
This is their second stop before they go home.
What I'm saying is, these people are very fragile and they can reverse very quickly.
Right.
And it's a shame, it's like a disaster when you have all worked so hard and then something silly, like, for example, a plug in the tracheostomy or something like that, kills them. So really, I like to see them going to the floor where they are really stable, not probably they can make it. Particularly because here we don't have step down. So that's another issue, because where I was, they went from ICU to step down, and then from step down to the ward. But if I look at my patients in the past, they spend more time in intensive care than in hospital. I mean, in hospital or intensive care, because that's the way I feel they do better. And there are not that many that hopefully represents a big problem. Other questions?
Is there, like I thought, okay, is there a patient coming with a very large thoracic abdominal aneurysm or thoracoabdominal, and they're probably over 75? Is there a cutoff age, or do you look at the comorbidities as well and take all that in effect?
We haven't staged this, huh? This is actually real. Because I was thinking, we have to talk of the indications. That's great. It's as if we staged this thing. That because we have the camera, so maybe it was all organized. This is all fake, guys. But that's a very important point. And the systemic point about your question is, when we offer surgery to these people, period. In other words, what are the criteria? And you will see that my preoperative assessment, in fact, it's a bit different, than what you see in the evidence-based literature. And the reason being is that evidence-based word is used by people who do not understand evidence either. And there is no evidence for thoracoabdominals. So if you try to apply whatever you have studied in risk assessment in thoracoabdominals, it does not apply. Because by definition, there were no thoracoabdominal patients, therefore whatever findings are there do not apply to this population. So what we are left with, if there is no evidence, what we are left is the expert opinion. Why is that? Well, I've seen the people. What do they die of? Well, they have their heart attack, they have a cardiac dysfunction, they die of complication of renal dysfunction, and they die of paraplegia. Because paraplegia increases the mortality 5-fold. So, we look at age first. But age is tricky, and in fact, I'm always a bit provocative. Right now I'm sort of tamed. My colleagues don't know me better. But somebody said, oh, this is 83, and therefore should we have operated on? Well, since it is a complex decision, I don't make that assumption. What I do is I go to the Manulife life expectancy calculator, I enter the age of the patient's comorbidity, and I get their life expectancy. Because we are doing a prophylactic surgery, and this applies not for these, but applies for any prophylactic surgery like aneurism and so on. If you're doing a prophylactic surgery, the benefit of the intervention increases only with the life expectancy. So to know the life expectancy is very important. And when we say 80 or 83, as a matter of fact, the life expectancy of an 83 is longer than a life expectancy of a 75, proportionally. And you'll be surprised, the life expectancy of a good 75 is longer than a 45. And the reason being that if you survive to 75, you probably have good system and organ, you're going to live. And you know, my father is 87. Now he's probably going to live 90, 93, 95 because there's nothing wrong with him. So it's very difficult on age alone, but because it is a prophylactic intervention, you have to know the life expectancy. So in those borderline, let's say the 75, which is we are entering the high risk group, I look at the life expectancy. If the life expectancy, let's say, is in the 6-8 years, then I go to the next step. What is the next step? First, the heart. No heart, no operation, no survival, quote and unquote. Parenthetically for you guys, never give up. I operate on 2 ruptured thoracoabdominal in whom we did a simultaneously off-pump coronary artery bypass and thoracoabdominal. And I have that on tape, and I sort of use it as a showpiece. But we assess the heart, and the way we assess them is we do coronary angiogram. I don't believe in stress test or butyrate stress test. I need to know before I get into the operating room that those coronaries are either fine or we make them fine. Either fine or we do angioplasty, stenting, bypass, whatever is necessary. And the reason is twofold. A, if they get cardiac ischemia and myocardial infarction, they die. But B, and I found this more important, it is difficult to understand if you are not in the business. When you are there in the OR, patient becomes hypotensive. The first thing the anesthetist will tell you, oh, his heart is not working. But it's such a complex environment. There is a million things that can go wrong that make the blood pressure go down. Going from electrolytes to your hemodynamic testing that is not testing right, to some electrolytic changes. There are a million things. But the jerk reaction is the heart is ischemic. That's why it's not. So once you enter in that idea, oh, he's getting a heart attack, then you don't look at all the other 100 reasons why the patient is actually hypotensive as a low cardiac output. So I eliminate that, because when the anesthetist tells me, but this was until recently, oh, he's having a heart attack, it really is not possible, because he has good coronaries. And last time what it was instead, and the anesthetist harassed me to no end until obviously I was right. Basically, we have a collapsed left lung, and he had a pneumothorax on the right side. That was the reason for hypotension. But the reason we did not give up was because I told him, it is not his coronary. I called the cardiologist who did the coronary angiogram in the operating room and said, talk to them. Has normal coronaries. I look at transesophageal echo, is pumping. It just hypotensive because basically it was compression of the cava and therefore no, anyway. So that's the reason why I have a very aggressive approach to cardiac assessment, which is basically one, coronary angiogram. You get information on contractility and you get information on circulation. This is controversial, but somebody else wants to do something different, is more than welcome. They just have to prove that they do better than me. So, that's the heart. The kidneys, ideally, you want a normal creatinine. Those are the people who do the best. Once you pass 200 millimoles per liter, in other words, once you get in the 20 ml per 1.73 meter square or GFR, the chances of dialysis post-op is 100%. Fortunately, the dialysis is not permanent. Even those with a creatinine over 200, after surgery, they stay a month, 2 months on dialysis, and then they come off. And this is because, as I stated, what I've learned through all this is that the kidneys are very resistant. Unless they get an infection, that is one thing that throws them off. In fact, if you have a patient in ICU that has borderline renal function, creatinine is 300, but he has good urine output, and all at once gets worse on the 7th postoperative day, 8th postoperative day, look for sepsis. Kidneys are extremely sensitive to sepsis. So, if somebody has a creatinine over 200, it's a negative predictor of outcome. So that has to be taken in consideration. Always it's a balance of risk and benefits. So for example, I've operated on some with an 11 centimeter thoracoabdominal aneurysm with a creatinine of 400. So, but when you get in a creatinine of 400, it seems simpler the decision because, well, you're going to go on dialysis, it doesn't matter. So do the operation, at least save your life, and then you go on dialysis. Because at 400, you're going to go on dialysis sooner or later, probably in the next year or so. But that's not the issue. The issue is the intraoperative management of somebody with a creatinine of 400 is very complex because they can't pee. So you can't rely on the kidneys to get rid of volume. So in that case, you would have to do intraoperative dialysis together with your extracorporeal circulation. But generally speaking, no, 200 and plus is a bad sign. So in this case, we have assessed lungs, we assessed kidneys, sorry, no lungs, we assessed heart, kidneys, lungs. And in fact, today we had a meeting, we do pulmonary function studies. If you look at the literature, and that was Swanson, Lars Swanson, who basically worked with Crawford and reviewed and summarized his experience after he died of 1,200 plus thoracoabdominal. What he looked at volume parameters as they affect respiratory failure post-op. To make a long story short, if they have an FEV1 greater than 2 liters, they usually do fairly well, if you want to look just at one number. So, again, we look at lung function. If they're good, then it's a better candidate for surgery. We try to bring to surgery people who most likely will make it, because otherwise we would do a disservice if we consider the population of patients with thoracoabdominal as a whole. So that's basically, in essence, almost all of it. There is one last point. I tend to tell this patient to be physically active before surgery. So I tell them walk half an hour a day, maybe twice a day, and take one kind of Ensure or any other per day, at least one per day. Or if they don't like that, a milkshake. Added to the regular diet, a milkshake. And the reason is I try to improve their nutrition also before surgery. So that's basically it.
One last thing. Say a patient arrives in a hospital symptomatic. You don't have time to prepare, do all these preparations for the heart, the lung, kidney. Or there's a chance they may rupture. You take them to the OR.
I don't take anybody to the OR.
You don't?
I go to the extent, you haven't seen my informed consent, which is basically almost 3 pages.
Yeah, I saw it.
Okay. I go to the extent with a ruptured thoracoabdominal to prepare that and have the family sign.
But
There are
what
very-
if they arrive in the hospital symptomatic, you don't touch them?
Unless they're fully investigated. I treat emergencies as elective because they don't survive if you rush them to the operating room. Now, you have to understand that the patient that is symptomatic, that is not ruptured, and the concept of symptomatic is a bit vague, but patients who have a pain that we can't find the reason they have an aneurysm, which potentially is the cause, is not ruptured. So it's an elective patient in the hospital. The system has to be, I could tell you in Hamilton, I could get the respirology, a choreangiogram done, and the nephrologist see him within 12 hours.
Or do they have 12 hours?
Sorry?
Do they have 12
If somebody is not ruptured, they do. We've just done one symptomatic, Mr. Singh, he was symptomatic. First, we tried to figure out if there was another cause of pain, and then we said, no, there are no other cases, we should operate on this patient. We did all investigations. And look how helpful was this morning with the issue of pain. They have pain, oh, it's the heart, it's the heart. Then she reminded, he has not my choreangiogram. You're right, you don't have to worry. So, again, we have to understand that these operations are so complex that if you rush in the OR, unless you have to sort of have a bank sort of mortgage you have to pay, if you rush them in the OR, you don't do much service because they do not survive. So, if somebody is ruptured, if somebody is truly ruptured, then there are 2 types of truly ruptured aneurysms. One that rupture around the diaphragm. Those people are very stable. And the reason is that the crus of the diaphragm, together with the parietal pleura covering the diaphragm, contains a rupture. And those patients are very stable. I mean, they will die, so you don't want to sort of do them next week. But they are stable enough that you make the decision, should I operate on them or not? And I had such a patient coming from Winnipeg, like Mr. Yoke. Just before I left, was my last patient I operated there. It was a ruptured thoracoabdominal aneurysm at the diaphragm, and she came in hospital, did a choreangiogram, and then I took him to the OR. So, if the patient is truly ruptured, I mean thoracic ruptured, and for some reason you think that it's salvageable, some reason means he's young, the guy has been water rafting until recently, even if it's like 60, 65, even 70, but in fantastic physical condition, then if everything is in place, I can tell you, in this setting that we have now, in this hospital, I would not take them, period. He will not survive. We are not set up in such a way to mobilize both resources, human and structural, to do that operation. But with time, perhaps we will get there. And in fact,